A big welcome back, everyone, to another episode of the Evidence-Based Hair Podcast. I'm dermatologist and hair loss specialist, Dr. Jeff Donovan. I'm also the director of the Evidence-Based Hair Fellowship Training Program. The podcast you're listening to is the official podcast of the Donovan Hair Academy. Each week, I review studies that are changing how we think about hair loss. I'll introduce them to you, help you make sense of them, and give you my thoughts on how a given study just might change how we diagnose or treat hair loss. Our focus for the month of June is JAK inhibitors. I'd like to start with a nice study from May in Expert Opinion in Drug Safety. A study from Italy titled Infectious Events in Patients with Alopecia Areata Treated with JAK Inhibitors, Low Burden and Minimal Impact on Persistence in Treatment. A very nice study which looked at the types of infections that occur in patients receiving JAK inhibitors and how they were managed. The purpose of this study was to review the incidence of infections in patients that are receiving JAK inhibitors, and for the authors to highlight whether patients stopped the JAK inhibitor or not. The key take-home message of this very nice study is that about 1 in 3 of your patients using JAK inhibitors are going to have some sort of infection. And so you have to be prepared for phone calls and emails and other communications with the office about your patients having infections. So let's talk about this really nice study. The authors from Italy set out to retrospectively review infectious diseases in their patients receiving JAK inhibitors. The study period was July 2021 to October 2023. They reviewed 91 patients, including 85 treated with baricitinib and 6 treated with upadacitinib. At this time, this interval, July 2021 to October 2023, ritlecitinib had not yet been used very often. It was just approved in Europe in September 2023, and so there were no patients in this study who had received ritlecitinib. So we have these 91 patients, and the authors observed 34 infectious events in 28 patients. So about 30.8% of patients had infections, and just over 5% of patients had multiple infections. Patients were followed for a mean of about 32 weeks, and infections started on average about 11 weeks after starting a JAK inhibitor in those patients that were going to develop an infection. About 1 in 3 patients overall had an infection. 50% of those infections were viral, 41% were bacterial, and 9% were fungal. The most frequent infections in these 91 patients who had infections were upper respiratory tract infections, herpes simplex viral infections, candidiasis, folliculitis, conjunctivitis, and gingival infections. What percent of patients needed to stop the JAK inhibitor? Well, 60% of patients with infections needed to stop their JAK inhibitor until the infection cleared. And the mean duration of stopping was around 13 days, so almost 2 weeks. It ranged from 2 days in minor infections up to 90 days in cases of a more severe pneumonia. And there was one patient in this study that needed to stop the JAK inhibitor completely. This was a 26-year-old woman with atopic dermatitis who had multiple abscesses of the skin, and they were resistant to topical and systemic antibiotics, and she just had to stop the JAK inhibitor. But really valuable information. Patients who email and call and outline that they have infection may need to stop a few days, but they may need to stop for prolonged periods of time, so be prepared for a week or 2 or more. I think the key message is it's hard to predict how long a patient needs to stop, but they need to stop until they get better if the infection appears to be a more severe infection. Minor infections don't always need to stop the JAK inhibitor. But overall, a really nice study. I like this study. It reminds us that about 30% of our patients are going to have infections. It doesn't mean that the JAK inhibitor caused the infection. It just means that human beings are prone to infections. And if you are treating a large number of patients with JAK inhibitors, you need to be prepared for about 1 out of every 3 of those patients to have some sort of infection. And a good proportion of those patients needing to stop. So you're going to be counseling a lot of patients about stopping and starting, when to stop, when to start. And that's a key part of the counseling that goes into prescribing JAK inhibitors. And about 5% of patients are going to have more than one infection. So really valuable information. I think that this data really is in line with clinical trial data, where about 30% of patients had infections. Doesn't mean that JAK inhibitors cause the infection. It just means that 30% of patients develop some sort of infection while they're receiving JAK inhibitors. What's so interesting about the BRAVE-AA clinical trials is they showed that both patients using JAK inhibitors as well as patients using placebo had a fairly similar number of infections. For example, in the BRAVE-AA1 clinical trial, a trial of baricitinib 2 and 4 milligrams against placebo, about 31% of patients treated with 4 milligrams of baricitinib had infections, compared to 28% of placebo patients. So infections are really common in human beings, and it doesn't necessarily mean that if your patients receiving JAK inhibitors have infections, that the JAK inhibitor was responsible. It just means that we human beings that are on the planet Earth really are predisposed to develop infections. But upper respiratory tract infections were amongst the most common infections in this study, about 9% of patients. That's quite in line with the BRAVE-AA clinical trials, where about 8% of patients receiving 4 milligrams of baricitinib had upper respiratory tract infections. In the BRAVE-AA clinical trials, about 1.3% of patients had herpes infections, HSV infections. In this study from Italy, it was 6.6%, so a little bit higher than the BRAVE-AA trials. The BRAVE-AA trials show that about 1% of patients had herpes zoster infections. There were no herpes zoster infections in this particular study from Italy. But stopping treatment is what will be needed with patients with more serious infections. And in this study, patients needed to stop for a mean of 2 weeks. And so it's a nice reminder that when patients contact you with infections that, be prepared to let them know that they may need to stop for a week or two. They need to stop until they're better. So don't be surprised if you're off your JAK inhibitor for a week or two. That would be completely expected in patients with infections. And vaccinations, of course, may help reduce the risk of infections overall, and we'll talk about that in our next study. But overall, really nice study from Italy highlighting the infections in their group of patients that were started with baricitinib and upadacitinib. I'd like to also review a very nice study from the US, from New York, in Archives of Dermatologic Research, again from May, titled Low Rates of Vaccination Among Atopic Dermatitis, Alopecia Areata, Psoriasis, and Psoriatic Arthritis Patients on Biologics. I really like this study. The purpose of this study was to review the vaccination status of patients before they started their JAK inhibitors. And the key message of this study is that most patients really aren't receiving vaccinations as they should before they're put on biologics and JAK inhibitors. And of course, I was particularly interested in the data on alopecia areata patients, but this study involved not only alopecia areata patients, but psoriasis and psoriatic arthritis and atopic dermatitis. So we don't vaccinate our patients nearly enough. We need to remember that there's a great deal of information that needs to be conveyed to patients before we start JAK inhibitors. We have to explain what JAK inhibitors are, the fact that many patients will need to be on them long term. We need to talk about side effects. We need to talk about payment and whether insurance companies will pay or will patients pay out of pocket for these medications. We need to review a lot of information. And we also need to review infections. And infections are common. We reviewed in the prior study that 30% of patients will develop infections. But vaccinations may help reduce the rate of many of these infections, like zoster, like influenza, and many of these pneumonias. But discussions about vaccination are pretty detailed. After all, we need to talk about influenza, zoster, pneumococcus, review hepatitis B, talk about TB skin testing and whether patients have been exposed to tuberculosis in the past, and maybe talk about other vaccines as well, hepatitis B vaccines, HPV, meningococcus, and other vaccines. This takes a long, long time. And so it's not a surprise, really, that many of our patients begin JAK inhibitors without full vaccination. And this study reminds us just how poorly of a job we do really in the world, making sure our patients are fully vaccinated before we start JAK inhibitors. This is a nice study from New York, but I think it's pretty representative of patients around the world that are starting these JAK inhibitors. Now, you may be aware, but let me remind you that immunization against zoster, influenza, and pneumococcus is generally recommended before we start JAK inhibitors. We need to test for tuberculosis as well. We need to test for HIV if appropriate. There's no vaccine for HIV at the present time. But what you might not be aware of is that zoster vaccination is recommended for age 19 and over now by the CDC. It's recommended for people 50 and over in the general population, but for age 19 and over if you're going to start a JAK inhibitor. Influenza vaccine is recommended yearly if you're going to be on a JAK inhibitor, and pneumococcus vaccination is recommended 19 and over in immunocompromised patients, like patients on a JAK inhibitor. It's recommended 65 and over in the general population, but 19 and over if you're going to be on a JAK inhibitor or some sort of immunocompromised states. So we need to review and consider vaccination for influenza, pneumococcus, and zoster. And don't forget, it's appropriate to check hepatitis B vaccination status, make sure the patient's tetanus status is up to date, hepatitis B I mentioned, HPV, human papillomavirus, Haemophilus influenza type B, Neisseria meningitidis vaccination, meningococcus. So really, a full review of vaccination status is appropriate, but of course, we tend to focus on influenza, hepatitis B, zoster, and pneumococcus when we're thinking about starting patients on JAK inhibitors. But this really nice study by Hren and Katri from 2024 from New York reminds us that our patients that are starting JAK inhibitors really aren't getting the vaccines that they should be. The authors from New York reviewed patients 19 and over in their group that were prescribed biologics or JAK inhibitors for a range of immune diseases like atopic dermatitis, psoriasis, psoriatic arthritis, and alopecia areata over the period 2003 to 2023. Vaccination rates among patients on biologics and JAK inhibitors were low, and they were significantly lower in patients 19 to 64 than patients over 65, and that makes sense. But overall, for all the patients in their study, about 9.39% were vaccinated for influenza, 6.8% were vaccinated for zoster, 17% for pneumococcal pneumonia, and 63% for COVID. And only 3% of patients were adequately vaccinated for hepatitis B after abnormal testing. But when we look specifically at data for alopecia areata, we see a similar trend, but the data specifically for alopecia areata was rather interesting, and that is in the younger age group, 19 to 65, about 4% were vaccinated for influenza. That was 13% in those 65 and over. For zoster, it was around 4% in the younger group, and 26% of patients 65 and over were vaccinated for zoster. And about 5% of patients 19 to 65 were vaccinated for pneumococcal pneumonia, and that was much higher in the 65 and over group. It was 37%. But still, whether you look at the older age group or the younger age group, you can see a dramatic number of patients just aren't vaccinated. And so it's a really nice study that reminds us that, as these JAK inhibitors get rolled out in the treatment of alopecia areata, and as more and more JAK inhibitors arrive on the scene, and as we start using JAK inhibitors for other conditions like scarring alopecias, there's evidence for JAK inhibitors being beneficial in LPP, FFA, CCCA, and the neutrophilic scarring alopecias as well. There's clearly a lot of room for improvement in our pre-counseling. There's a lot of room for improvement with the vaccines that we connect patients with. For our younger patients, we know now that patients 19 and over are candidates for zoster vaccines, the yearly influenza vaccine, and the pneumococcal pneumonia vaccine. And so there's a lot of room for improvement, and our younger patients can be connected with these vaccines, and it is appropriate to do so. And I think that, probably this is a shared responsibility of drug companies, and insurance companies. I think that, one of the things that's very much a focus when I fill out forms for starting JAK inhibitors is, has your patient received TB skin testing? Has your patient received TB skin testing? Has your patient received TB skin testing? None of my forms really ask me, did your patient receive zoster vaccines? Did your patient receive pneumococcus vaccine? Did your patient receive influenza? How about COVID? Have you given thought to, meningitis vaccines, HPV vaccines, et cetera, et cetera? Well, they don't. And so I think some of those forms really could be modified quite easily to prompt clinicians to think more about influenza, pneumococcal pneumonia, and zoster vaccinations. But we have a large room for improvement, and that's okay. The reason for the podcast is so we can all improve. But I think more training of physicians that are starting JAK inhibitors is really needed. It's a really comprehensive process, an exhausting process, really, to start a patient on a JAK inhibitor if you do a good job. And it takes a while for either yourself or your delegate to really review all the information that's needed for your patient to make informed consent. Patients need to understand the risks and benefits. They need to understand the long-term effects, the short-term effects. For alopecia areata, most patients that are starting these JAK inhibitors need to understand these are lifelong treatments. And so they need to understand these issues really well. And that in and of itself takes a long, long time. And the vaccine piece takes a long, long time as well. And so if you're going to vaccinate for influenza, zoster, pneumococcus, and others, you can see it's going to take time. But there's room for improvement for all of us. And I think that's really important because herpes zoster infections are very much a part of the infections that patients with JAK inhibitors get. Some of these infections can be serious. And with JAK inhibitors, many patients have mild infections, but up to 2% of patients have more serious infections. And if we can do something to reduce the risk of more serious infections, well, why not do it? And these vaccines do offer us some of that kind of protection. Many of these vaccines are best done before we start JAK inhibitors, but some of them can be done after patients on a vaccine. After patients on a JAK inhibitor, of course, they can't receive live vaccines, but they can receive the influenza vaccine. They can receive the new zoster vaccine, which isn't a live vaccine. But, the best time to do it is before we start these JAK inhibitors. So I really like this study and congratulate these authors for sharing such valuable information. And I'll leave the references in the show notes. The entire month of June is dedicated to JAK inhibitors. Next week, we're back talking about a fascinating study of generic tofacitinib in the management of alopecia areata. Generic tofacitinib offers an incredible cost savings compared to the brand name Xeljanz. Is it any good? Does it help? Does it help just as good? I'm using a lot of generic tofacitinib in my practice. I look forward to sharing this study with you. I'm sure you'll be as fascinated about it as I am. Thanks so much for joining me this week and for the month of June as we talk about JAK inhibitors. I'll see you next week here for another episode of the Evidence-Based Hair Podcast. Bye for now.